Welcome back to Finding Common Ground with Heather and Steve. Today we're going to delve into a topic that a lot of people probably have a lot of things to say about. When we think of healthcare and we think of those instances where we need some help and we hope that it goes well, and doesn't always go that way, right? So each of us had these personal experiences, and often what we do is just kind of shove them off to the side and hope they don't happen again. But there's actually an organization called the Institute for Exceptional Care, and their mission is to really delve into this topic and make sure that everybody's needs are met in a way that's really respectful and effective. So I would like to introduce Dr. Mai Pham. She is going to share a lot of great information. And Steve was the first one to connect with you. He's more familiar with your organization, but everything I've learned so far has really made me very excited about our episode today. So thank you for joining us.
Thanks so much for having me. I'm super honored knowing just how, what leadership you both have exercised in New York over the years.
Thank you.
Thank you, Doctor. And Heather and I are in my ever-ending quest to find answers and solutions to some of the difficulties and roadblocks we run into with our own kids and other kids that we advocate for. I actually stumbled on one of your Zoom sites, and I was so impressed because Heather will tell you, I'm on a lot of different things. And I was impressed with the way your approach was, that you were looking at a little bit more than maybe just your own little region. Like a lot of times we get siloed into our own particular area. And the problem isn't something that just is a New York problem. It's a problem across the United States. So I was wondering if you could tell us a little about the Institute of Exceptional Care, which you happen to run.
Sure. Thanks, Steve. So I myself am mom to a young adult who's autistic, and it was our coming through their first mental health crisis that really made me ask a lot of questions. Now, I'm a doctor, and I've also worked in health policy for over 15 years. So the fact that I felt clueless about how families with developmental disabilities lived, I realized made me actually kind of typical of other healthcare leaders. I wasn't the exception. And that led to a lot of conversations. I would just talk to anyone I could find who could tell me anything about why things felt so hard. And that's how we sort of, and by we, I mean me and our co-founders, arrived at the conclusion that there was a need for a different kind of advocacy organization that could really bring a systems perspective to the problem. Many of us have spent years trying to change the healthcare system, and the American healthcare system is a beast. It's complicated, it's meant to confuse you, and it's meant to be difficult to change, right? And when there's that much money sloshing around in a certain space, it makes change difficult because there are lots of vested interests. So we thought, well, there's no way that community members alone can make this set of changes happen, because the deck would be stacked against them. They don't have those insider relationships, and they don't know where all the skeletons are in the closets in healthcare, and frankly, how to manipulate the decision makers in healthcare. And we thought, what if we pulled the best from both worlds? What if we brought our healthcare experience and street cred, as well as our lived experience supporting loved ones with IED, and some of us have disabilities, and we married that with really true, authentic partnership with people with lived experience. I don't just mean disability organizations. I mean like real individual people who aren't necessarily trained. They're just contributing their perspective, which is valuable enough. And so that's why we started IEC. And our approach, as Steve says, is we're playing the long game. In our diagnosis, there are many problems in healthcare, but there are 3 areas of gaps that are really linked together. It is how healthcare is taught, how it is delivered, and how it is paid for. So by how it's taught, we mean how do general clinicians, the ones who aren't IDD specialists, how do they learn about IDD? We need them all to know how to deal with it, because all of us are going to get older. We're going to develop diabetes or heart disease or cancer. And I really need that oncologist to be ready to explain complicated chemotherapy options to someone with IDD. We all need those anesthesiologists to know how to assess pain and consent in someone with IDD. So that's how healthcare is taught. But you can't really ask clinicians to invest in the time to learn if they don't also see you working on improving payment for their services. And payment right now is terrible. It rewards the wrong things. It doesn't reward all the invisible work that the best clinicians and clinical practices do. Things like all those phone calls to coordinate home and community-based services, or all the time they spend filling out SSA forms or checking on you or preparing you for a visit. None of that gets paid for. And then you can't ask insurers and government to pay for something if you can't tell them, well, what is the thing that I'm paying for? What is that care model? What is that ideal package of services and best practices that I should set as the gold standard for the providers that are in my network? Who am I paying for what? Right? And so that's why we have those three pillars of our work. And we see our value added as not replicating the work that so many groups like yours have been doing. You are doing the really hard stuff of advocacy on the ground. But what we want to do is to elevate what you're learning and the changes you're making and help that scale and spread. So that's why when we talk about training, yes, we do develop some new training materials where we see there are gaps. But we also want to promote the materials that are already out there, and we want to hardwire that desire to learn into the system. That's why we're working with groups like the Association of American Medical Colleges, or the same analogous body for nurses, because they can reach thousands, tens of thousands of clinical learners and really elevate the impact of what all of our advocacy friends are doing. Similarly, at some point in the future, not now, but in the future, we will get the accrediting bodies, those organizations that are responsible for giving out licenses to clinicians, to require certain competencies and certain knowledge about IDD and IDD in the context of other healthcare decisions. And that is what hardwiring means to us. Let me pause there. And, I think that hopefully that captures, Steve, the essence of what you sensed about IEC.
Yeah. Doctor, it's interesting. You know what I liked about your organization probably the most is Heather and I are always searching to bring our advocacy to the providers, to bring it to the state, to bring it to get legislators to get answers for some of this. But your group was so willing to add advocates and family members and self-advocates right away. And we sometimes have to fight to get on some of these, to get a seat at the table. And it's hard. And I think you're doing the right approach by trying to include us who are on the ground, so to speak, to help you guys, because it's going to take all of us.
And I think that there's so much variation too across the state, across the country. So one person's experience in California could be radically different than what happens in Idaho, right? And you won't really know when to pivot and what to focus on if you're just listening to one person or one entity or one organization. And that was what really spoke to me too, seeing the self-advocates there who might not know the solution. And we say that too, Steve and I, when we bring people together. It's not that you have to know how to fix this, but you have to help us break it down, because then that system change feels doable because you can see where the breakdowns are. You can see where the gaps are. First, I worked in education as a school psychologist and really did some very complex assessments. And I was in the homes and daycares and schools, wherever the person was, I would meet them there. And I'm so glad that was the beginning of my career because I was in the homes with the families. I did have a sister with autism, so I was probably more predisposed to this. I grew up knowing what it meant to be different and how to embrace that. But I started my career well before I had children, and now I have 4 children with varying levels of need and challenges and wonderful gifts as well. So if I hadn't had that little glimmer in the beginning to see the families interacting, especially in that beginning stage when you were talking about diagnosis. Now, as a school psychologist, I didn't have to diagnose, but I really, really had to get that family ready for that step. Like we had to look at what was going on, and I had to put it in a way that didn't crush them or freeze them in place. Right? Because sometimes something sounds so scary and so overwhelming that people get stuck and then they don't go the next step. I'm not going to talk to that doctor. I'm not going to make that appointment. And I have to be honest, that appointment can be so hard. And when I was in that position, I could say, I'll go with you. I understand the language that they're using. I know the terms and I know the abbreviations, and we can get through this together. And I was so happy I could do that for families. Now, fast forward, 17, 18 years, there's not as many people, at least in our state, and you might be able to reflect on, the country as a whole, that early intervention piece there's not as much funding, there's not as much focus on it as there used to be even 10 years ago. We've actually lost ground. So families not only don't have the in-home support at the same intensity and frequency, they're definitely not getting somebody with that expertise and experience to go to those appointments with them, which puts them at a disadvantage. I mean, I'm sure you've talked to a lot of different people. What would you say is the hardest part of those first initial appointments? Because you talked about the diagnosis. I mean, once you actually get an appointment and you're actually in the building, because we all know that could take a long time with wait lists.
Yeah, I think not being able to leave with some sort of support system in place is one of the hardest things. It was one of the hardest things for us. We were given Alex's diagnosis and then just kind of floated off on our own. And I don't know what people thought would happen, but good things didn't happen from that. I think it's also difficult to judge whether I personally would want that clinician to say very much, because right now most clinicians are so poorly trained. I'm worried they might say the wrong thing.
Yes.
I think many of them walk around with outdated assumptions about quality of life or life expectancy or what is possible for that person with the right supports. And we hear so many stories of those early appointments being doing tremendous harm because the clinicians took away hope.
I was going to say the very first
and they blamed parents and families, and sometimes even the affected child, for things that really were the fault of the system.
Yes. I mean, that is so true, because my daughter has a rare genetic disorder and we didn't know what we were dealing with. Here, it's kind of funny considering the hundreds of children that I had helped, clinicians diagnose. And then I had my little girl, Devin, and I had no idea what was going on. It was just so different than anything I had seen. And she started having seizures. And I explained what I was seeing because they weren't traditional seizures. She wasn't jerking around and moving. It was like she was freezing and she couldn't breathe. They were very scary. And the neurologist looked at me and said, with her hand, lowered her hand down and said, "You're going to have to lower your expectations. Your child's autistic." And I said, "Lower my expectations. She's having medical events. She can't breathe." She said, "That's very common in kids like your daughter." And that was there was no discussion on how to remediate that, how to resolve it, how how to make it better, I had to find other family members who were going through something similar to have any idea what to do next. And that's a very lonely feeling, especially, 18 years ago when the internet is not what it was then, right? So it was harder to find people and connect.
Yeah. I want to go back to the other theme that Steve hit on, which is it's hard to get access to the important decision makers. Sometimes that's because those decision makers don't want to be bothered. They have other priorities. But oftentimes it's because they've never known how to work any other way. They might have a formal period for the public to submit comments on a regulation or a law, but that doesn't really help community members feel heard and understood. So what IEC tries to do is to create those spaces where we put the decision makers in the same Zoom room, and sometimes the same room with real community members. And we are not surprised that that makes our self-advocates and family care partners feel empowered. That was the intent. What did surprise us was the reaction from the healthcare leaders. They walk out with some combination of delight, awe, humility, and passion. We have gotten page-long thank you letters from health insurance executives coming through our projects who say that has changed me. It has changed how I think about our work and our programs and how I will engage community members. We had a federal official invite us in to teach his team how to engage community members. And nearly every single healthcare leader who has been involved in our projects would agree that the solutions were better than if they had designed them themselves. And that, we think, is one of the reasons that they feel so relieved when they come out. One, because when they walk in, they don't know what to expect, right? We're having to role model them things like how to speak slowly and using plain language and explaining complex concepts and waiting and pausing so that people have time to process and respond. But you have to understand that most healthcare leaders are stressed nearly all the time because they are expected to always have the answer to everything. And we're creating a space where they don't have to do that. They can, it takes them a little effort to pull back initially because they're not used to doing it. But when they do, they realize that community members are giving them so many insights, the solutions kind of present themselves. And the group works on that together, and the pressure is off of them. Don't underestimate how valuable that is to healthcare leaders. They know that they get it wrong a lot of the times, and it actually ends up costing them more money in the long term to assume they know, build something, figure out it's wrong, have to build the next thing, right? Rather than investing the time and effort up front, get input from your end users, from your community, and build the right thing once.
Makes a lot of sense, doesn't it? I mean, you wouldn't want somebody to come and decorate your home, but never ask you what you like or what makes you feel happy. And then you end up with a house that could be beautiful, but not your style. It's a very basic example, but it's so true. If we don't know how people are going to respond and how they feel, especially the breakdowns. I mean, sometimes when you talk to a healthcare leader, because after education, I got recruited. into healthcare, and I was in a 500-bed facility, a long-term care facility, and they wanted me to help them be more person-centered. It was such a shift because we went from, everybody has an individualized plan, and even though you have one in healthcare, somebody else writes it. Like the family and the loved one are not part of that situation. They're not adding input. So we're like describing you the way we see you. And it's really just for each other. You don't even see your life plan a lot of times, your individualized plan when you're in a healthcare setting like that, at least back then. I think things have evolved a little bit, but it's from that kind of advocacy and those kind of discussions where we would have these meetings to break down a case, and I'd say, let's invite Douglas in. He's the patient, he's the resident. Let's talk to him. And they would look at me like, oh, he's going to sit with us? Like, how is he going to help us? And he knows what he's living. He knows what he's experiencing. And he knows what happens when he shows up at dialysis. He can tell us what happens with transportation, where the breakdown is, why he keeps missing his appointment, or whatever the case may be, right? Like, he's the missing link and the most important part, because whatever solution we come up with has to work for Douglas. So I love the shift in the way IEC is looking at it and doing it in a respectful way, because Steve can comment on this, but when we go to Albany or we go to DC and we have our signs and we're screaming outside and we're protesting, in that moment we might feel empowered. There could be news cameras there. There might be politicians that come out for that photo op. But what happens when we fold up our signs and get back in our car and drive home? We don't always get a whole bunch of change from that. We could have hundreds of people, thousands of people show up. We don't get as far as IEC has gotten because we're yelling at each other instead of talking. I think that's a defining point and a difference for your organization.
I suspect that we need all kinds of different approaches in advocacy, and I'm grateful that you guys are out there yelling. It's just where we are IEC best positioned to contribute, because we do have those relationships and we can empathize with the healthcare leaders. It means they know that we're not going to propose solutions that aren't possible for them to follow through on. But we do want to hold them to a higher standard than has been done in the past. And we say to them, look, if a tiny nonprofit of 7 people on the East Coast can invest in authentic community engagement, you have got to be kidding me that a $2 trillion agency cannot. No, I'm not buying it, right? But we can also explain to community members why it's so complicated for healthcare leaders. So, for example, when we try to build this app called Always Uniquely Me to help people with IDD and their support persons advocate for themselves in emergency situations, like with first responders or in an emergency room, we designed the tool initially, put all the elements in it that community members really, really wanted. And then the clinicians who were also in the mix and the payers who were also in the mix said, no, first, I really need to know about your allergies and anything life-threatening. And I have exactly 2 minutes to read through. So the number of fields of information has to be something I can scan in 2 minutes. And so we adapted. The whole group did. And that's practicing what I like to call multilateral empathy. We're looking for the win-win-win-win-win, right? Where all stakeholders are not just having their perspectives understood, but absorbed into the solution.
Yeah, Doctor, I wanted to mention something also. We have it's interesting. A lot of the providers that we go to, like the kids that I either have in my home through foster care, or some of the ones I work with, they go to some of these providers, and I used to have the mindset that they just didn't care about our population. It was all about the money. They didn't want to do any of that. But you know what? What happened? I started getting to know some of these doctors in our area, and they did want to take care of our population. And the problem was they were getting like $7 on a $150 visit. And they finally would say, I can't do this anymore, Steve, I want to. And yet these doctors were fantastic with my children. And then what happened is we couldn't take them there anymore. And then what happened is we couldn't find a place in in central New York to take him. And now we have to drive 2 or 3 hours to get us the same thing that we used to get with him locally. And it leads me to what you were talking about with the paying part of it, which is a big factor. But it's more that the doctors and the professionals in this field, they want to help. And I've seen it. And if you guys have the answers to that, I think you're going to answer a lot of the parents' prayers.
They do and can help. They're underconfident because no one has trained them appropriately. And when clinicians, especially doctors, are underconfident, I know my own kind, only one of two things happen. Either they lash out or they shut down. And neither of those is good for anyone. But yes, the other reality is they have staff to pay and rent to pay and other patients to see. So the bits of hope I can offer is that Medicare, which is the insurer in the country that pretty much sets the standard for all other insurers in terms of how they define billing codes and levels of payment. And then Medicaid and private insurers will kind of play off of that Medicare approach. Well, Medicare, just in the past couple of years, has begun offering what they call time-based billing, especially for physicians, clinicians like those who provide primary care. So you have a more complex patient, you spent more time with them, you can bill that higher code. It doesn't solve all the problems, trust me. We just wrote a 16-page comment letter to changes to the physician fee schedule in Medicare last month. But there are these small steps that are being taken in that direction, giving clinicians more flexibility in how they bill, maybe giving them some payments up front to help pay for upfront investments. Like, you can't hire a nurse coordinator by waiting 3 years to bill enough, right? You need something up front. You can't add dimmable lights to your office without some upfront investment. So some payers, not many, but some offer those types of what we would call infrastructure investments. So all these small movements in that direction are what we're trying to aim for. And we do that with some opportunities in Congress, some opportunities with Medicare and Medicaid, and in our day-to-day interactions with health plans and in the coalitions that we build. So we're working on it.
It's a big task.
Yeah.
It's not an easy one to solve, for sure.
Doctor, could you maybe explain some of the programs you're using? I know I'm part of your advocate core, and I think I'm on your community work group. Several different ones. Are those? They're very inclusive because they let me get on them as a parent and advocate. And do you have other ones also, or I'm not sure if you have anything else?
Well, in terms of participating with us, we have community members, which include self-advocates and caregivers and care partners on every single project. So sometimes we recruit for individual projects because we know certain people have certain interests, and we kind of try to do that matchmaking. Other times we might put out a broad recruitment call, and then we usually set up a short online survey that you can go to and fill out, and then we select people from there so that, to your point, Heather, that we're getting geographic diversity and racial ethnic diversity and age diversity and all of that. One of the things you're referring to, Steve, is an initiative of ours called the IDD Advocate Core. And this does not fit into the how healthcare is taught, delivered, paid for rubric, but it kind of supports all of them, because what the core is an advocacy network, kind of like what you've already built, but focused at making big change. And in that network are self-advocates, lay self-advocates, lay family members, and then healthcare professionals, some of whom are also caregivers or people with IDD. So what's different about this network is that they are working shoulder to shoulder on making the change. And there are different committees in that network, in that advocate core, like working on communications or working on policy issues. And then over time, there'll be more and more work groups that target a specific area of healthcare to make change in. The first one, which is one that you're on, Steve, is the health system work group. And that work group just stood up, and its goal is to have its members go and make change with their local hospitals and local clinical practices. And then maybe together they can make change with big groups like the American Hospital Association. And among the ways that they can make change is IEC can share with the advocate core all the things we're learning. So for example, that app, we're getting ready to test it now on Long Island, but other communities can adopt it now. If the health system work groups wants to run with that, have at it, right? Or we're figuring out now what are the best ways for health system, like emergency departments, to organize their tools and their equipment to better serve our people. Advocate Corps can take that and push their local communities to adopt it. Any of our training programs, Advocate Corps can push that with their local, medical societies or nursing societies. So that's kind of that idea, Steve, is we know that IEC is never going to be big enough to be everywhere with everyone. But we think it's important to not just have this movement, but also to do it in a way that kind of like echoes that, healthcare connection piece with the community lived wisdom piece, because we think that that's really powerful.
And when you start local, it doesn't feel as big or scary, maybe, right? You start local,
exactly.
The hospital or the provider. The one call that I was able to join for IEC, there was a woman and she was talking about the ED. Now, I've been in the emergency department more times than I wish I would ever have to be in it. And she had said that as somebody with low support needs who can really function quite well on a day-to-day basis in that environment with all the background noise and the pain that she felt and the stress and the worry that she had, she was having a really hard time focusing and making important decisions about her own well-being. And so then she started thinking about what would make it better for me and other people with similar, the way they function. How could we help this group of people? And she found that just a quiet space that was not in the middle of all the flow and all the noise, and it was somewhere you could really regroup and have a conversation was really important to her. And implementing that in one hospital, and then somebody else is going to see that and go, that's a really great idea. And I think that's how it catches, because then you have proof of concept. Instead of coming at the federal level or even the state level and saying, we want this. We said, in Utica we did this, and in Rochester we duplicated it, and then look at over here in Manhattan, they're trying it, and it's working. How can we develop a program or an initiative, funding, whatever the case may be, to make sure that people all across the country know about this and that it works? Because, like you said, we can come up with the best ideas, but unless we're trying them in a small scale first and piloting them, we really don't know how it's going to play out in the big picture. So I love the strategy behind it, the taking it slow, but still pushing.
Yeah, I'm the granddaughter of an actual communist, so I've learned over time, you don't always want to announce the revolution. Sometimes you just want it to sneak up on people. And one of the great things about a tool like that app is we don't need to wait for a health system to decide to use it. If it belongs to the community member. So if they use it and they start showing up in doctors' offices and clinics and EDs with that app, those providers are going to start wondering, right? And that's what it means to give power back to where it belongs.
I love that.
Doctor, a couple of months ago, I had a meeting with the senior vice president of Wynn Hospital. It's the only hospital left in Utica, Rome area. And I had a one-on-one with her, and I remember her, I laid a whole bunch of things out that I thought they needed to do because I didn't think they were doing enough for our community, the IDD population. We have kids in their emergency rooms and for a variety of reasons because there's nowhere else for them to go. But I remember her telling me I need the data. I remember we need, is there trainings, is there data? And I didn't have that. And it's one of the reasons why I like what you guys are doing is because you guys can help me, give me information, including that app that I can bring in there and show them that we do have something that can help, or show the families around here, like you said, and just do it on our own and bring it to them.
Yeah. Listen, I know that reflex among healthcare leaders to say, I need the data. What you want to say back to them is, certainly, if you have the data, give it to them. Okay. And that's why we're doing this very expensive $1 million evaluation on Long Island for the app, which costs only $5 per person per year. But what you want to say back at them are at least two things. One, you already do many things for which you have no data. And we're telling you that they don't work for us, and they probably don't work for a whole lot of other people too, not just people with IDD. Okay, so that's point one. The other point is, most of what we're asking you to do is super cheap. So can you give us a gesture of goodwill? Can we work on something together so that you can see that it will help your people as well as us? Because your teams are stressed out right now when visits don't go well, when ED encounters don't go well. Let's find a solution that works for all of us.
I'm going to set up a follow-up meeting.
Yeah, no, but see, that's the coaching part. Some of us are brave enough to walk in the office and start the conversation, but we need that back and forth with other people who've done it before, who know the language, who know the tone, and what's going to really resonate with different people. I know we only have a little time left, so I want to make sure we hit on some of the hot topics when it comes to healthcare. And at least in New York State, dental care has become at a crisis proportions right now. I mean, children are waiting 1 year, 2 years, sometimes 3 years on wait lists if they need sedation or any special accommodations. I recently had a dental office in Rochester charge me $125 to make an appointment that they weren't even going to see my daughter. We were just going to talk about what they thought they could do. And it for a lot of families, that's out of reach. They're not going to be able to make that appointment. They're going to have to hang up, and their child's, like Steve has talked about, he's had foster care kids that are in his home, and nobody's taking the Medicaid because it's not covering, their expenses. And then they end up in an ambulance because they have an abscess and they're septic, and it was a cavity. It's like such a simple fix, or even preventative. They're not getting the cleaning, so they don't get the cavity to begin with. So I don't know if you have any feelings on dental, but it's really a big deal, at least where we are.
I think that we probably need multiple solutions to this. I think about a concept like a dental health parity law, the same way we have a mental health parity law that is going to start being enforced more rigorously now. I also think about this really interesting approach that Delta Dental has been taking the past few years in certain regions. So Delta Dental is one of the two largest dental insurers in the country, and they have different regions. Their upper Midwest region, which includes Michigan and Iowa and a few other states, a few years ago began offering these new billing codes for special needs patients and expanding coverage to cover things like more frequent cleanings for people with special needs, those preparation visits, the desensitization visits, and also allowing people to see more than one dentist in a given time period, because sometimes you have to shop around, right? You and I know. So you walk into some practices and you know that's not going to be a good fit. Well, you can't just stop there. But in addition, they also offer higher payments for those dental visits and procedures for someone with special needs. I would love to see that a program like that embellished and copied by Medicaid, by other dental insurers, because now that it's being done, and that modifier code that says this is a special needs patient is available to any payer who wants to use it. It exists for Medicare providers too. So for people who have both Medicare and Medicaid, that code is there. It's a question of the payer following through with the policy. Yes, when you put that code on, I will pay you X amount more. And state Medicaid expanding that dental coverage to those kinds of accommodations. Delta Dental is particularly committed to the IDD population, but I don't think they're doing this out of the goodness of their hearts, right? To them, it's not costing that much. It really isn't. And it gets them a lot of goodwill, right? Because people with IDD, guess what? They have family members. All those mamas out there, those mamas are the ones making the healthcare decisions for their whole family. So they're going to bring their whole family to a dental practice that does things like this.
It's so true.
I'm just saying.
Yeah, no, that makes a lot of sense. Steve and I have talked about a few ways to incentivize it for dentists. And that's that right there is not even anything extra. That code is already there. But just the idea of, when you graduate from dental school and you have all those loans, or any doctor, psychiatrists are in the same, any physician has a lot of school bills. What if there was loan forgiveness? Or what if they got extra tax breaks if a certain percentage of their patients used Medicaid? Because it's really a barrier.
Well, that is what the Heads Up Act is about. That is a piece of legislation in Congress right now that has bipartisan support. Unfortunately, it's an election year, so who knows what will get passed in the lame duck Congress. But the Heads Up Act would define the IDD population as a medically underserved population. That's a very formal, legally defined term that would then allow federal agencies and other organizations to do things like offer loan forgiveness or offer higher salaries.
I have not heard anything about that. Thank you so much for that nugget.
It's called the Heads Up Act, spelled just like how it sounds.
That's wonderful. It feels like that concept could be so much bigger than just that. When we talk about the IDD population, I almost always say we're the largest unrecognized minority group. And if we had that status of being, we could legally define ourselves as a minority group, there are certain things that would just fall into place, certain safeguards and considerations when we're denied certain things that we're entitled to. Not that we want to call it a hate crime, but there's just different levels of severity when we're denying access or making life harder for somebody in a minority group. And it's not that I want the label, but when you just explain the Heads Up Act, I was like, because it makes sense, right? You need to be defined in some way.
Medically underserved literally means that you're not getting the care you're supposed to.
Mm-hmm.
And in the past, it has often been driven by data on which groups are having the worst health outcomes. So on that score, we've won the argument. There is no doubt that our community has worse health outcomes. And it's mostly not because of biology. People with intellectual disability, aside from age, I don't know if your audience know this, but in the early years of COVID, aside from age, having intellectual disability was the single strongest predictor of COVID death.
Wow.
That is not biology. That is about how people arrived in EDs, about whether they were given ICU beds, about whether they got ventilators, about whether they got vaccinated, right? That was not biology.
That was basic PPE.
So,
You think of group homes and the comptroller in New York State. He had quite a lot to say about how our Office for People with Developmental Disabilities shared information with staff and safety procedures, and then how it trickled down to the actual people who were living in those settings. And it brings me to a point. It made me so sad working in a nursing home during COVID. It was very, very difficult to live through that experience in any setting. But in healthcare, in that long-term care facility, the people were so lonely. I could walk out to the parking lot and hug their family member who's just standing outside the window. And I can drive home and I can hug my kids. And they couldn't. They were just so isolated. And that was the elderly, that was the sick, that was people who lived with disabilities that ended up in that 500-bed facility. And I always go back to it. And I did a recent study at Autism Up where I'm the director of advocacy, and we were looking at housing specifically, but it's always more than a roof over your head or finding the right doctor. It's like so much more. It always is. And 74% of the people that we surveyed said they were incredibly lonely. A significant amount of loneliness. And then you look at the Surgeon General and you see that that's worse than smoking daily, to feel lonely on a regular basis. So the work you're doing with your organization, it spans across so many quality of life issues. But the biggest part is being respected and seen as a fellow human. Not, it's like demystifying if someone can't speak verbally, that they're not speaking or they're limited, that they don't have anything to say. It's like opening that door and unlocking this potential for people to see each other for just being a fellow person. And that's just invaluable to our society on so many levels. How can people get involved with IEC and help with your mission?
Well, first of all, please, I invite you to visit our website, which is ie-care.org, and look around at some of our major projects. We didn't put all our projects on there, but hopefully that will give you a good sense of the kind of work that we do. Please look at signing up for the IDD Advocate Corps. And if you see a project we're working on or an area that we're working on that you have an interest in getting involved in, and or you want to connect us with potential partners, drop us an email through our contact page, and we'll get to know you and figure that out. And then, of course, like all nonprofits, we look for donations and funding. So any of those types of connections would also be quite welcome. And if you have a forum where you think it would be helpful for IEC to share our approach or share our learnings, just like Steve and Heather have brought this to us, do let us know, and we're happy to do that too. We're still young. We're only 4 years old, so we're building community, and the more the merrier.
Thank you. And I also, it's not that this would be a reason why people have to be involved, but there's actually stipends, if I remember correctly, for people who are participating that are self-advocates. And I bring that up because so often we're put on advisory boards and councils, and we have to come up with ideas that aren't always listened to or valued. And this is structured so different. You're like thanking people for giving their time and their resources and their talents in a way that really matters to someone who's living paycheck to paycheck, or they're struggling in their own ways. And I just want to thank you for that, because that is something very special, and it might not be always available. And I know it depends on funding streams and grants and all those things, but the fact that you thought of that part, and to make sure that you're speaking to the whole situation, because there are so many groups I want to be a part of, right? But that there's only so many hours in the day, and you've made this an opportunity that people should be excited about embracing. So thank you so much.
Well, that's you shouldn't thank me. That's an obligation. We do that in every project. We pay for community members' time, and their contributions. And then we always offer them the opportunity to be listed as co-authors on work products or co-presenters. Sometimes it depends on what journal the article is appearing in, how many authors they let us list. But, if you look at the article we had in the Journal of the American Medical Association in August about the health policy agenda to improve outcomes for people with IDD, it had 43 authors.
That's wonderful, though. Wow. Look at the collaboration.
Yes. And so it is important to us. One of the unsaid things that maybe we should make clearer on our website is that for us, it's a privilege to be in every conversation that we are with community members and especially self-advocates. And we know that that experience is helping community members grow and feel fulfilled. So the money is our obligation. We have to pay. That's like non-negotiable. But that personal growth and that sense of community, to your point, Heather, about feeling alone, what IEC can offer is that, you will have lots of opportunities to not feel alone.
Lots of things
you might
to work
want
on.
to turn your emails off. Anyway, well, thank you so much for having me. It's been a delight.
Thank you,
Doctor,
too.
Thank you so much, Doctor, for coming on. I'm going to actually going to try and promote your app. I think that would be beneficial to a lot of the families that Heather and I work with. I'm going to do a follow-up with Win. With that little tidbit you gave me, and I look forward to continuing to work with you guys. Like I said, I was impressed from day one. I ran right out and told Heather immediately about this great organization that I stumbled upon, and keep doing what you're doing, and know that the families in New York, we're going to do everything we can to help you guys.
Thank you so much.
Thank you.
Take care.
Thank you.
Continue the conversation by joining our Facebook group. If you're a fan of the show, please join our supporters club. Subscribe on YouTube, rate and review on your favorite listening app, but most of all, share it with your friends. Just one more click or comment can make a huge difference and help us to continue finding common ground.